So my talk is entitled Disruptive Technologies. How many people know what disruptive technologies are out there? Raise their hands. Just a few people. Well, I put this talk together because I heard this tossed around a lot, and I quite honestly was really not familiar with disruptive technologies. And so I looked it up. It was actually described by a Harvard Business School professor, Clayton Christensen, a number of years ago, and that disruptive technology is one that displaces an established technology and shakes up the industry, or a groundbreaking product that creates a completely new industry. So when we think about it, there are a lot of things that have happened in the last few years: internet, artificial intelligence, space colonization, 3D printing. I'm going to focus on medical innovations in a minute, particularly as it relates to urology and prostate. High-speed travel, robotics, blockchain technology, autonomous vehicles. I mean, 5 years ago, when somebody said to me, they're going to have cars driving around by themselves and we're not going to be driving them, I'd like laugh at that. And, you know, it's happening in our lifetime. We have it, you know, even in Colorado, out by the airport, going to hotels. So it's very interesting what's happening. As I looked at this whole thing about this disruptive technologies, to me it seems like most of the time these things were constructive, but they can flip back and forth between constructive and destructive. And so not everything is positive. And as an example, I'm going to talk about some of the urological things that have happened, particularly with PSA. So my focus in this talk is primarily on prostate, and a lot of it has to do with biopsies. We are being inundated with a whole host of disruptive technologies which start out to be constructive, but actually flip and become destructive. And, you know, our goal is, can we get them back on track? So we're going to talk about PSA, prostate biopsies, imaging, genomics, and things like that as we go through this. PSA is a prime example of a disruptive technology. I think it's bounced back between constructive, destructive, and now we may be on back to construct. But there's no question, it was a breakthrough marker. It was heralded as one of the most important tumor markers in oncology, and it still is. It has unprecedented ability to monitor disease. So there's not many disease sites where you can do a simple blood test and determine the sort of the disease state. Is this person cured with a radical or radiation, things like that. It's inexpensive, and it can be obtained in a matter of minutes. And the early detection of prostate cancer, there's no question that it had an impact on initially finding the prevalence of the disease. And the prevalence of the disease is the incidence times the time people live with it, and the incidence. And now we're sort of back to the incidence of the disease. But the destructive part of PSA became very obvious. Patient-stimulated anxiety. People sort of literally lived and died by their PSA levels. Before they want to see me now, they want to know what their PSA is. They expect it to have it. Physician stress amplifier. It did create a lot of stress with us. Overdiagnosis and overtreatment. Isoforms sort of led us, we thought that was going to be a way forward, and that sort of led us down the wrong track. And the attempt to say who needs to be biopsied, and we'll talk about that. Can we make PSA constructive again? And I think we can, and that's by innovating and looking at some things. And one of the places we need to start are with family practice doctors who order 90% of the PSAs in the United States, and who we confuse with all sorts of cutoffs, all sorts of genomic tests and densities and things like that. They need a sort of a simple message. And my simple message is based on the fact that we can define a PSA cutoff below which there's very little risk of prostate cancer or aggressiveness, and that's 1.5, or 1.5 to 4, where there's a gray zone. Now, I need to make it clear is that in that zone of 1.5 to 4, that's something you want to watch. It's like a little bit of elevation in your temperature or your fever. What does it mean? And it may mean BPH. It may mean that you have prostate cancer. It may mean prostatitis. But what we've shown is that contained within that 1.5 to 4, there are a lot of men that harbor prostate cancer, okay? So we want to recognize that. And then, so 1.5 to 4 is sort of a changer in the way that it signifies it's disruptive in the fact that it signifies that this patient is not in a stable condition and they may have BPH or other things like that that need to be watched. So the disruptive technology comes in genomics and a new aid to help us determine who to biopsy and whom to biopsy. And we have that right now with some of the new genomic tests that are out there that help us signal, okay, this guy's in a gray zone. I think that it's not just BPH, but it could be prostate cancer, and we want to do a biopsy. We have these tests, Select MDX, and to a certain extent, Phi and 4K score. So we have a way to deal with this sort of gray zone and move forward and make PSA great again. So the other thing that I want to focus on right now are prostate biopsies. We go back a number of years here, and in fact, it was 1954 when one of the first needles for histology and biopsies were described, the Vin Silverman needle. And then we started doing aspirations. And then the true cut, which is really sort of a harpoon. And when I grew up as a resident, we used to biopsy the prostate transperineally with an anesthetic in the hospital to diagnose it. And then fine needle aspiration was just beginning and actually looking very good. And all of a sudden, what sort of disrupted that was ultrasound and transperineal and transrectal biopsy. So we had the introduction of the BK ultrasound machine into urology practices, and we had Dr. Kuhner and Fred Lee talk about these, and Dr. Stamey about doing 6 biopsies and then looking at doing 12, things like that. But it became apparent also that the most dangerous weapon today was a urologist and a bioptic gun. Why? Because we were finding a lot of cancers that did not need to be found, and we were also creating some issues with infection and things like that. So the ultrasound-guided prostate biopsies, no question, it's disruptive technology. Transrectal, described by Fred Lee and Kuhner and others, and Valencian and the group talking about transperineals, and which are actually gaining a lot of traction today. So, but it's 30-year-old technology. Prostate biopsies, the destructive part of them has to do with the side effects and so forth. We do 1.2 million biopsies of the prostate every year in the United States, 3.4 worldwide, to diagnose not a lot of prostate cancer cases, 180,000. Do the math. We have a lot of negative biopsies. And most of these are done in the office, and some are done in the OR. So the optics have changed. The transducers, the probes, from side fire to end fire with more accuracy. But some things haven't changed. But what we've done, and this goes way back, and we're working with Neil and Stone and 3D biopsy and others to do these transperineal mapping biopsies where we go through at 5-millimeter intervals through the prostate. We'll do, our record is 186 biopsies. That's a lot of biopsies. It's about 2 biopsies per gram. It gives our pathologist a headache, but they do it. Well, we've worked together with pathology, with Dr. Miller and Dr. Lucia, and with others to put together a 3D model and also map this to show that before we start on doing targeted therapy, that we are treating, we can find all the cancers and not miss anything. But it also creates a lot of problems that need to be solved. And we look at the transperineal template biopsies. It's a lot of biopsies, but maybe we can make it a little bit different by looking at some of the technology and making disruptive technology. And one of the things we just sort of live with is the fact that we have about a 17 millimeter core that we do consistently. But how many prostates are 17 millimeters? Maybe there's a way to dial in the volume of the prostate, the length, and shoot a core that. And that's what this disruptive technology is a variable needle where you can adjust it from 15 to 60 or so in the core, and you can keep the core in there. Well, that's something that's doable, and it's something that's happening right now. And we will, as we go through here, we will see that happening. Okay, I can't advance this thing. Right click, okay. Okay, there we go. 3D biopsy is the trademark for what the company that we're working with that's trying to put all this stuff together. And it includes not just only the needle, but the software and so forth to be able to assess what's going on in the prostate. And basically, we've shown that if you do this, it's a needle prostatectomy. It's the same as taking the prostate out, okay? So it is a disruptive technology, and there's various components of it that we'll hear more about at this meeting. All right, so let's go on and talk about some other things. And one of the other things that we're working on in Colorado is an optical biopsy needle. Basically, it's shining light and getting reflection, fluorescence, and saying cancer or no cancer. That's it. So you put a needle in, diode is the light, you get a reflection back, and it's called the Claricore system. And basically, what you get is sort of an answer. And we've done this, been working on this probably for about 7 years right now, and we have ongoing studies at Hopkins Memorial, Tuck, and also with Neil Shore and his group in Myrtle Beach, and looking at the ability to diagnose cancer with this. And this is something that is going to be presented at our national meeting very shortly, but it's some new data on the negative predictive value of this test is 97%. So if this thing comes back negative, you got a 97% chance that you don't have cancer. So I think that that is important when you look at, we do all the biopsies we do every year, and 90% of the biopsies we do are negative. Is there a way to cut down on these by this light technology? And I think the answer is yes, and it has applicability to other tumor sites. Pathology, as it is practiced today, is some ancient technology. Put something in formalin, fix it, slice it, stain it. Things are changing. There may be a way to have integrated learning machines, digital age. I mean, so what do? You get a second opinion on a biopsy. You FedEx the slides across the country to an expert that looks at them. Why can't we do this over the internet? Why can't we do it in a digital age? And that needs to be done. And there are people that are doing it. I know Scott Lucia's working on it. We also have Matt Levitt and his Lumia technology, which I think is very exciting. What their sort of their game changer is their biopsy board that you put the slides in, or the biopsies in, keep them lined up. You can have AI look at it, give you a measurement for a gross for your billing and so forth, and then process it all within the biopsy chip staining it, things like that, and so forth. What I find is interesting. There's some challenges with this. There's no question. Like we're delivering 50 millimeter biopsies. They don't fit in the standard cassette. And Neil Stone is working on this, a way to deal with that. Another way is to accommodate it with something like this. But I think the exciting thing also that's happening is artificial intelligence and reading pathology slides. And the pathologists are going to be sort of reluctant to let the grip go on this. But I mean, we're seeing this everywhere with artificial intelligence. We talked about earlier disruptive technology, self-driving cars. AI is everywhere right now, and it's a supplement. It doesn't replace the doctor. It makes your life a little bit easier. And so some of the data I've seen with AI and pathology and radiology and other things are important. Prostate imaging. There's lots of discussion at meetings about MRI. There's no question that MRI is disruptive technology, but there's some downsides in missing significant cancers, the cost effectiveness, the technology, the observer variability. You really need to be an expert to do it. And fusion biopsies and things like that are out there. The group at UCLA just presented this at one of our meetings this summer, Rob Ryder, and what is seen in about 612 patients are that there's no question that MRI does eliminate finding some of the Gleason 6 cancers, but it also finds a lot of the higher grade cancers, the 8s and the 7s. But the lower portion of this is it still misses some of the higher grade cancers. And that can be, depending on who you believe, 25% down to 5%. And so I think that is an ongoing issue that needs to be solved. And what needs to integrate here, and I'll talk about it in a minute, are genomic markers to help you go forward. The other thing for using AI, and that is interpreting MRI and making it look better. We worked on this some 15 years ago with ultrasound, looking at pixels and seeing by using artificial neural networks, can we make the ultrasound reading easier? Could never get that to work. But this is something that Priya Warhar and the group in pathology is working on with our radiologists, looking at areas of interest and then calling them out and then getting a read on it that gives you better. And I'll show you this in a minute with a couple of patients. And basically, we're just getting started on this. But what you can see here is that regions of interest, it has a pretty good reflection of what's going on here up near the 90 and 100%. So it does improve things. Fusion is of interest. When you find something on MRI, how do you get a biopsy? Well, image fusion is the process of combining relevant information from 2 or more images to provide a more informative image than the original input images. So to be able to do this and look at it. And so if we look at night goggles, we have the night out there in the darkness, but you can bring out a subject or area of interest by wearing the goggles. And sort of the same thing can happen, and they're doing it in a lot of different tumors, is using technology to make lesions stand out. So if you look at this MRI fusion biopsies, there's some advantages. I don't think that there's any question. You have an improved yield. You can do, by choice, fewer total biopsies, better accuracy, but it's sort of a self-fulfilling prophecy, and a lot of us may be able to see some of those images on ultrasound, and I'll talk about that in a minute. And it adds confidence. The disadvantages are cost, may diagnose irrelevant cancers. It may take image guidance out of the specialist's hands, which may bother urologists, because that's happening in a lot of places right now where they're doing in-bore biopsies and the urologists are not involved. There are platforms that help the fusion. UroNav, Eurostation, and Artemis, and they're all out there and people are using them to help the question is, if you're really a good ultrasonographer, maybe your results with the cognitive biopsies are about the same. So I would say about multi-parametric MRI, there's no question it's disruptive, but the jury is still out. There's no question that detects higher grade lesions. We are really lacking in incorporating genomics into this whole thing, about whom to rebiopsy, confirm MDX, select 4K, things like that, all these things that help us determine who ought to be biopsied. And in the hands of the less experienced, fusion biopsies are probably better than cognitive. But there's, I think we're in a thing where this disruptive technology is becoming somewhat destructive technology. One of the more important things that I've seen in the last year as a disruptive technology is micro-ultrasound. And what we know is, and that's why we have gravitated to MRI, is that systematic biopsies do not find enough of the right cancer, so to speak, and their false negative rates are high. And we have basically abandoned ultrasound as a visualization tool of the prostate itself, but use it more to determine volume and also to guide biopsies. And maybe there's a way to go back and start looking at the ultrasound and seeing what you see. So the normal ultrasound that we use and we're into the news are basically in the 7 to 9 megahertz range, some less, some more. But now ultrasound is available at the 29 megahertz level, which gives you a 300% improvement in resolution. So you can see more. It's like looking at an old black and white TV versus 4D now that we have and things like that. So you got better resolution. And also, if you believe in it, it enables real-time targeting of biopsies. It is available, it's just becoming available in the United States. We have had one in Colorado for about 4 months and have had the opportunity to study it. Basically, these are the images you see. This is not what you normally see with an ultrasound. And then I think one of the downsides of this is the learning curve. It's a whole new learning curve. And you know, you start looking at, well, maybe this area here is not so perfect. We've got some smudginess and we have some indistinct borders, and we see a little calcium in this one, and so forth. And what you can do, and you start seeing stuff like this, you actually are able to see the lesions. What does this remind you of? MRI, to me. And this is an in-office MRI, which is about the same cost as the ultrasound machine that we're using right now. And so you have this advantage for real-time visualization, real-time targeting. It's 300% more resolution. And the company has a fairly extensive training online, which is good. And then they've come up with, you know, we have the PIRADS. Theirs is the Primus system of 1 through 5 that grades these lesions. And so this is just getting started. I think there are significant learning curves for urologists and radiologists, but there's some advantages. You don't have a 40-minute MRI. You don't have to read and score it. You don't have to fuse it. You don't have to perform a targeted biopsy. You don't have to reconfigure the patient, complex workflow, multiple patient visits, costly with reimbursement codes and high variability. So this is putting things back into the hands of urologists, and you know, hopefully that this is going to pan out. The last two things in disruptive technology I want to talk about deal with, first of all, infection. We still use the same method to culture bacteria we have for over 100 years. And that's the auger plate and streaking and sensitivity disc. And so everybody is familiar with this. And this is Cox stuff. And then we get a report back. And we get things back that say, well, multiple organisms contamination, or not 10 to the 6th or 10 to the 5th or whatever. And we have different things. So we've been using that for a long time. Things have changed. And we could spend a half an hour talking about what's changed. What we culture with the standard things are called planktonic bacteria, which are the ones that get away in your bloodstream and your urine and spread. But because of vaccines, because of multiple antibiotics, we have altered our whole microbiome, and there's a lot of interest in microbiome and biofilms. And biofilms are a proteinaceous way, in a way, that bacteria survive in a little environment where different bacteria help each other out. And we have an area that, it's sinusitis, joint infections, urinary tract, stones. It's a whole new thing right now we have to think about. You don't get those bacteria plated out. You've got to find it through new, innovative ways. And so what are the new, innovative ways to look at that and deal with all this stuff? And we're going to hear more and more about this. There was a presentation at the EAU meeting on this very thing about biofilms and infections and rectal cultures and things like that. So disruptive technology is next generation sequencing of bacteria and fungal things. So this is traditional report. You have E. coli, you have maybe 10 to 25,000 count, and you have these sensitivities. Well, what's happening is, one, you can get instantaneous read now from PCR of common bacteria, so like 30 of them. But the next step is quantifying it and looking at it, and that's next generation sequencing, where you can identify up to 30,000 different species, quantitate them, and look at broad spectrum treatment. This is great for, it's sort of creeping into urology right now. We have actually sent off over 100 and some specimens to look at this to see if there might be a bacterial, fungal sort of etiology for prostate cancer. Who would have, when this meeting started, when Stone started this meeting a while ago, we didn't know that there was this thing called Helicobacter that caused stomach cancer. We know a lot of cancers are caused by inflammatory bacteria and also viral things, hepatitis we know about, herpes, all these other things that happen, cervical cancer, and it goes on and on and on. So anyway, I think this is the future right now, and we're starting prostatitis. We kind of write people off. Interstitial cystitis. They're finding, like studying women, that they actually do have something wrong with them. And it's a whole new area that's a game changer that's disruptive in urology. Prostate genomics, it's basically finding the bad guy here. And I've talked about this earlier, whom to biopsy. We have all these new genomic tests to help us. Negative biopsy, who to biopsy. We have confirmed MDX, select MDX, 5, 4K. We have things that help us, and people that have sort of low-grade cancers or 3, 4s, whom to treat. We have Oncotype, Prolaris, Decipher, and so forth. So we got a lot of new disruptive technology here. Prostate treatment modality. We know Dr. Whitmore said, is treatment sufficient for those in whom it is necessary and necessary for those in whom it is sufficient? We have some wise people have said we have more people making a living from prostate cancer that die from it. And I think that's true too. We need to cut down the number of people that die from the disease, obviously. So seek and destroy was the 20th century. Now it's target and control. And our urology colleague from MD Anderson, Andy von Eschenbach, said that when he was the director of the NCI. So we talk about targeted therapy, identifying the lesions, focal therapy. I think that the key is that what bothers me about people doing focal therapy and targeted therapy, and I don't believe in it the way it's being done right now, is they're looking at MRIs to do it, they're looking at cluster biopsies and things like that. You need to do the right things. It's like ready, fire, aim. We need ready, aim, fire. You got to know what you're aiming at to accomplish this. There are lots of ways to ablate prostates, and we hear about it: lasers, HIFU, cryotherapy, electroporation, AC ablation. I don't think that's the issue. Is knowing what you're treating, and to me, that's the big letdown that occurs. So I don't really believe in focal therapy, which is currently practiced, although by a lot of people. Although we've done many hundreds of them, but it's done based on science and knowing where the cancers are. And so I think that's what it's all about. And so I think that also we need to eliminate active surveillance. We don't want to put patients on active surveillance. We want to find them. So we have genomic markers that help us. So my last minute or so is, in my opinion, the most disruptive technology in medicine is EPIC and the EMR, quite honestly. Who do they serve? Patients, hospitals, and payers. Look at a note you wrote 10 years ago versus today. It's 4 pages of garbage, of, cut and paste and this and that, and were you out of the country in the last 6 months or so forth. What do I care as a urologist? But, we've lost it in a way. And what's happened is who's getting the advantage of that? And, I think it's right here, front page of the Denver Post. It's the payers. They're 75% hike in prices in the last 7 years, and their collections are also going up. Why? Because a lot of it's documentation and things like that. They play hardball with some people. This was also in the front page of the Denver Post, and that was Kaiser blames hospitals, and where they don't have a hospital and they're sort of being shut out. So this is the other thing that I think is the most disruptive technology that's created a genetic mutation in humans. It's changing how we communicate, learn, and behave. This has put us all on call as physicians 24/7. I get beeps on my phone when something comes back on Epic. Patients need to get a hold of you. You're never alone. You're always in touch. And we talk about physician burnout. Physicians, this was from Urology Times, they love their iPhones and everything else that are out there, and they're real. But I'll tell you, when you look at a situation like this is a problem. You have young kids that are all standing around, not talking, and they're listening to their phones and looking up stuff. This is a sad situation, and I think this is a destructive technology. So, thank you.